So, my sincere and humble request to all the participants here. Yeah, it will be a workshop for quite a few weeks. We are going to go through all the important aspects of clinical aspects of ECG, and it is going to be conducted every Tuesday and Thursday as per the program of the Department of Medicine and also Principal Madam. And I request you all to log in as early as possible, maybe 5-10 minutes earlier, so that we save time. And this will be on the Zoom link, recording, and be available for others to view at a later pace. Okay. So again, once again, my sincere thanks to Dr. Sudhir Garu for proposing to do this workshop, and also to Principal Madam for facilitating this, not only Department of Medicine PGs, but also to others. So welcome all for the ECG workshop. It's a nice and thrilling experience to do it once again. We had the opportunity to do it twice in GEMS College already for the previous batches. Nonetheless, every time we do it, it is a new experience for me. It's a beautiful morning to start off on an important subject for all of us. Let us look at that. Already we are seated, of course. So a clinical approach to ECG interpretation. What is non-clinical about ECG? Everything is clinical. But the thing is, we are going to look at only clinical examples and how it has a clinician one would look at, not as an electrophysiologist. So certain things will not be objectives of this workshop. So just let us pay homage to this great teacher. Om Sri Gurubhyo Namaha. Alan G. Lindsay is a teacher of substance and style. He lived between 1890s and 1960s. So around 70 years, this gentleman lived, a beautiful player of violin and also a teacher of substance, and whose contribution we have to acknowledge here when we start learning ECG, and I'll show you why. Joseph Goldberger, the father of electrophysiology, basically is a physiologist turned into electrophysiologist, and his book on ECG is the gold standard. His name is having gold, and his book also is a gold standard. Let us pay homage to the teacher there, the Goldberger and Alan Lindsay, and have my humble obeisance and salutations to all those great teachers. When I say all, I recollect so many of them who are instrumental in making us what I am today. The present and the past, who enriched us with the knowledge and made possible today's advancement of medical science. Let us all remember that learning is a continuous and unending process. My humble obeisance. The non-objectives of the CME is, we are not going to discuss the electrophysiological basis in depth about each waveform. And of course, the details of arrhythmias are out of scope of a workshop. One can do a separate workshop on arrhythmias itself. Nonetheless, I would have given you some idea about how to diagnose common arrhythmias and conduction disorders. The sensitivity and specificity, ECG is a diagnostic test. We are not going to evaluate the sensitivity and specificity of ST segment elevation or presence of Q wave and things like that. That is a little beyond the scope of our workshop. Atypical and rare presentations are the rule in ECG rather than an exception. Atypical presentations do occur in different scenarios, and we will not get into them. Combination pathologies also will be there. We will not get too much into them. Scoring systems are there. There is what is called, you score each wave and then make some predictive values and all this. It's a very extensive understanding of the ECG. And there is what is called the vector ECG. We are using scalar ECG, and we are not using the vector ECG in this workshop. So the resources that are there, as part of it, I acknowledge humbly and then record my sincere thanks and gratitude to those resources. And because this is going to go online, without acknowledging the help of others, we are not going to do any better in science. Alan Lindsay's Cyber ECG Learning will be the primary learning center for all of us, and I am going to use that learning center very much during our interaction in this workshop. Interactive is electrocardiography by Novartis, a CD-ROM in those days. Now it is available as a soft copy. Those of you who are interested, I can share that with you. Frank H. Netter is just immaculate in medical drawings. You see any great medical drawing, medical picturization, there will be a signature called Netter. So Netter's drawings are used in this, and also American Heart Association sites, American Heart, Lung and Blood Institute sites, J.G. Webster's Cyber ECG library, over 2000 ECGs are there. Brandmar's textbook of cardiology, and Joseph Goldberg's textbook on ECG, and our personal collection of interesting ECGs are also included. As a teacher, I have collected many interesting ECGs during my clinical practice, and luckily I have saved them, and some of them will find place in this workshop. So be blessed we are. Today's learning resources are innumerable. We have access to all the latest material. Electronic formats of data storage are there. Tele-ECG facilities for remote areas. Single channel, 3-channel, multi-channel, PC-based, printable versions, Holter, TMT, stethoscope ECGs. I have one stethoscope like that, which demonstrates the Littmann stethoscope. Just place on the chest and it gives the ECG. And I also have a very tiny portable ECG. The machine is only this size. You can put it in the pocket and go to any field. And you see coronary angiograms and perfusion studies. When I say TMT here, I would like to run 1 or 2 sessions on TMT also, because majority of the postgraduates are not familiar how to actually do the TMT and also interpret the TMT. And you can actually do it in your wards, and along with hands-on experience from here, I can demonstrate to you about the TMT, which is a little outside the scope of ECG, but in the broader sense, of course, it is also ECG. Now, interactive electrocardiography, Novartis CD-ROM will look like that in the opening page, and you can click to learn from that. Now, this is Ellen Lindsay's Cyber ECG Learning Center. This is the website when I started first looking at, and the beauty of this Lindsay's website is it has got 13 modules. So we will be covering a module by module. What is module 1 to everything I will explain to you. And today the architecture of the website has changed a lot of interactive way. They have redesigned it, and thanks to the Dr. Young, who is the student of Dr. Lindsay. Dr. Lindsay, as we said, is the father of this clinical learning. And when we go to the website, we will see him again in the picture there. He lived up to 1960s and collected several ECGs during his clinical practice. And his student, a very faithful and wonderful student, he is now already is an emeritus professor. Dr. Young is his student. He collected all those ECGs. In those days, there is no electronic format. And once the age of electronics has come and the digital world has started, he started a learning center under the name of his revered teacher. What great service a student can do to a teacher of that nature. Young himself is a very renowned electrophysiologist and cardiologist, and we will be using some of the Young's modules also for doing our exercises. And all the modules of exercises are created by Young. The ECGs are, of course, partly from him and partly from his teacher, Alan Lindsay. So we have to start anything from the basics. So some of you may be very, very familiar with the basics. Kindly bear with me that I have to go through this, otherwise the newer generation students may not be able to understand the process correctly. So we start with ECG paper, part 1 of this, normal intervals and voltages and ECGs, rate determination, simplistic approach, leads, limb and chest leads, selected rhythm abnormalities, QRS volt to axis is normal right and left of the ventricles, that is the QRS axis, and also the axis of the atria and T wave also in certain situations. Hypertrophy like left ventricular, right ventricular, left atrial enlargement, right atrial enlargement, and of course bundle branch blocks and left and right. So what will be part 2? Part 2 will be, of course, arrhythmias, infarction and types of angina, all acute coronary syndromes and miscellaneous. Part 3 will be arrhythmias. So it will be done in 3 parts. Arrhythmia part we will see depending on the interest we will go, but first 2 parts are part of the plan. So let us start. It is going to be a flow of beautiful river there, nothing like nature, and just imbibe the content that is presented to us by great masters, and remembering that I am only a vehicle through which it is flowing, and I am not the author of any one of these things. So the ECG paper, time and amplitude. So any recording should have an x-axis and a y-axis, right? So the x-axis here is the time measured in seconds, because cardiac events occur in fraction of a minute, 0.8 seconds. Like that, in a minute, there will be 70, 80 events occurring. So the time has to be in the seconds, and it is on the x-axis, because everything is dependent on the time. And the time of the wave, a particular electrical event takes is the basis against which how much it does is the amplitude, which is the y-axis. So the x-axis bears the time and the y-axis bears the amplitude in millivolts, not in volts. The current that you are getting in your household is 220 volts. And what the heart is generating is 5 millivolts, 10 millivolts. And that little current from the Paramatma is propelling us throughout life non-stop every minute. So that little current has to be recorded here. In fact, it produces even microvolts only in the heart, that is amplified in the ECG as shown as millivolts. We don't even have millivolts current. It is even microvolts current that has been amplified on the paper to show that it is in millivolts. So again, the x-axis is the time in seconds and y-axis is in the millivolts, amplitude in millivolts recorded on the ECG paper. The paper more or less looks like this. You can observe that there are small squares with the lighter colored lines, not heavy lines, light lines, and also you can see heavy lines there. There will be heavy horizontal and vertical lines, and there will be less heavier or lighter lines also there. So if you look at a small square, like the sorry. Yeah. So again, if you look at the ECG there, the small square, the smallest of the small squares, as you can see the arrows there, 0.04 seconds. So the area covered by one small square on the x-axis is 0.04 seconds. How many small squares are there? You just count. There are 5. 5 small squares make a larger square. Each small square of 0.04 multiplied by 5 is equal to 0.2 seconds is the time interval of between one darker line and another dark line. Okay. So this is important for you to know. So because the waves occur as 0.04, 0.08, 0.12, 0.1, 0.24 like that. So unless we are able to measure this very correctly, we will be making error. So the x-axis contains time. The smaller square, the smallest square has got an x-axis interval of 0.04. And a bigger square is 5 times the smaller square, which is the 0.04 multiplied by 5, which is equal to 0.2 seconds. Right? So the bigger square is 0.2 seconds and smaller square is 0.04 seconds. Then what is the scale on the y-axis? The small square is 0.1 millivolts. That is 1/10 of a millivolt. 0.1 millivolt is the height of the wave that occurs if it crosses one small square. Likewise, 5 small squares will be 0.5. 2 such 5 small squares or 2 big squares is equal to 1 millivolt. So vertically, 2 big squares is equal to 1 millivolt. Horizontally, 1 big square is equal to 0.2 seconds. Suffice to know this, and we will go for the next one. So it is like any other graph paper. X-axis represents the duration, Y-axis represents the voltage or amplitude. It is called amplitude here. It is of course the voltage. And X-axis 1 millimeter is equal to 0.04 seconds. Y-axis 1 millimeter or 1 small square is equal to 0.1 millivolt. 1 big square on the X-axis is equal to 5 times 0.04, which is equal to 1 big box is equal to 0.2 seconds. And Y-axis 2 big squares is equal to 1 millivolt. Okay. Now, so I've given a bigger paper. I am showing now instead of showing a smaller paper. As you can see again, there are smaller squares and there are darker lines also. So we know that the 5 small squares will require a time of around 5 millimeters distance, and that is 0.2 seconds because 5 into 0.04. Okay. So in 1 millimeter, if the paper moves, 5 millimeters into 1, 2, 3, 4, 5 big squares will be 5 big boxes is equal to 1 second. You understand that? Each big box, each darker line enclosed big box is 0.2 seconds. 5 such will be 0.2 multiplied by 5, which is equal to 1 second. So if the 1 second will be traversed by 5 big squares. Small square I have already told you, 0.04. The time interval is represented on the x-axis. Cardiac events occur very precisely in small time frames of milliseconds. Heart doesn't wait for 3 minutes to know that you wanted to see whether there is infarction or not. It goes on doing its work. In that you have to pick up whether there is an ECG change or not. 1 small square is equal to 0.04 seconds and is 1 millimeter in size. And each big square is equal to 5 times the small square, which is equal to 0.04 multiplied by 5 is equal to 0.2 seconds. 5 such big squares will make 1 second. 0.2 into 5 is 1 second, which is equal to 5 into 5 millimeters. Each big square is 5 millimeters. 5 such big squares is 25 millimeters. 1 second is 25 millimeters or 5 big squares. Then 1 minute will be 60 times that. That means if the ECG paper ran for 1 minute, it would have crossed 300 big squares. Why this is important? We will learn now. So normal ECG has got certain wave complexes. Let us familiarize with the names of these waves, then proceed to look at the ECG. So ECG complex has got a P wave, a QRS complex, a T wave, and a U wave. This is a very fundamental concept you need to learn. What is a P wave? A P wave, as you can see here, is a wave that is produced because of the atrial contraction. That one is remarked as P wave. And an interval usually includes the wave as well as the segment. There is what is called the PR segment. That is at the end of the P wave and the beginning of the R wave. Maybe I will make it whole screen for all of you to understand, so that you don't require to look at my video, rather look at the graph. So let me come back here and then use the pointer so that I'll be able to show you what exactly is going on. And so this is the P wave, which I am showing with my pointer. And from here to the beginning of the QRS complex is called the PR interval. PR interval includes P wave and the PR segment. When we come to the next slide, we will see what is that segment. And this inscribed wave QRS is called the ventricular complex, or due to the ventricular activation. This is atrial activation, and then PR segment is a slight delay at the checkpost AV node, and then the ventricular complex QRS. Then the horizontal part is the ST segment, then the T wave, and a little U wave may be seen, may not be seen. And this is the duration of the QRS from the beginning of the QRS to the beginning of the T wave or end of the QRS. Sorry, not the beginning of the T wave, end of the QRS is called the QRS, and QT interval is from the beginning of the Q wave to the end of the T wave. So what did we learn? And there is another interval called between one R wave and another R wave is called the RR interval. So what did we learn? Well, we learned that P wave is atrial contraction, QRS is ventricular contraction, and T wave is ventricular repolarization. Then where is atrial repolarization? It is there, but it is submerged in the QRS. So atria also repolarized and depolarized. First, depolarization is P wave. Repolarization is not seen in the ECG. This is depolarization or contraction. Electrically, it's called depolarization, and mechanically, it is called contraction. And after that, there is the repolarization of the ventricle, that is the T wave. And U wave, we will see when we come into details. So there is a P wave, there is a QRS complex, there is a T wave, and there is a U wave, and there is a PR interval, there is a QRS interval, there is a QT interval, and there is an RR interval. Okay. Usually, the QT interval should be less than half of the RR interval. Not on, half of, less than half of, less than half of the. So this is the RR interval. What is the RR interval? Cardiac cycle. What is the cardiac cycle? 0.8 seconds. Half of that is 0.4 seconds. Okay. So if you have half of that is 0.4 seconds. So RR interval will be usually 4.4 QT interval will be usually 0.4 seconds or less. So very important clinically when the QT interval is prolonged. In COVID also we know that we cannot give HCQS when the QT interval is prolonged. There are several drugs which cannot be used when the QT interval is prolonged. So a very important interval in the ECG is the QT interval. Likewise, PR interval also is important for the conduction. I told you PR interval is due to the delay at the AV node. We will try to relate these waves to the cardiac cycle. Okay, in the next slide. Now, P wave is due to atrial contraction. How much is the P wave size? We will show you on the graph. It is only 3 small squares. 3 small squares is 0.04 into 3, which is equal to 0.12 upper limit. The P wave should not be more than 0.12 seconds. PR interval is from the beginning of the P wave to the beginning of the QRS complex. So that is here, beginning of the Q wave, P wave to the beginning of the QRS, and the upper limit of that is 0.2 seconds. QRS is ventricular contraction. Normally it is 2 small squares, that is 0.08. So it is a very crisp, brisk contraction, 0.08 seconds. If it is more than 0.12, we say QR interval is prolonged. QRS interval is widened. We say it is widened. Then ST segment is isoelectric segment. QT interval from the beginning of the QRS to the end of the T wave. So this is the beginning of the QRS and the end of the T wave, and that is what is called the QT interval. It should be less than half of the RR interval. RR interval is cardiac cycle. Let us say if the cardiac cycle is 0.6 because of tachycardia, 100 is the heart rate, cardiac cycle will be 0.6. In 0.6 is 1 cardiac cycle. In 60 seconds, 100 beats are occurring. Then what should be the RR interval? Not more than 0.3 because half of 0.6. So it depends upon the rate. Then there will be a correction called QTC. That is the QT interval corrected for the rate. So if QT interval is dependent on the rate, one need to correct the QT interval to the rate of the heart. Then only we can interpret whether a QT interval is longer or shorter. So you understand? It's a very important concept I'm telling you here. P wave is atrial contraction, 0.12 seconds or 3 small squares. PR interval is from the beginning of the P wave to the beginning of the QRS is PR interval. Its upper limit is 0.2 seconds or 1 big square. QRS complex is very brisk and crisp. It is occupying only 2 small squares or 0.08 seconds. ST segment is the isoelectric part of the ECG. This we call it as fate line of the ECG. Why it is fate line? The extra segment is elevated, it is dangerous. It is depressed, it is also very significant. So it should be horizontal. And the T wave is the repolarization wave. And from the beginning of the QRS to the end of the T wave, beginning of the QRS to the end of the T wave is called the QT interval. And this should not be more than half of the RR interval. What is the RR interval? The interval between successive R waves, successive ventricular contractions, otherwise known as the cardiac cycle. Normally it is 0.8. QT interval will be half of that or less. Because QT interval is rate dependent, we require to know a corrected QT interval, which is called the QTC. Okay. Now, this part we learned. Now let us go to the another easier way of understanding now. Now we made it very crisper. I would like you to identify each wave in your mind. When I say one, it is P wave. So that is the atrial contraction. PR interval is beginning of the P wave to the beginning of the QRS, and you see a little segment here after the P wave and before the QRS. This is called the PR segment. Why this PR segment is occurring? This is the delay at the AV node. So the impulse arises from the SA node, traverses the atria, and completes the atrial contraction and arrives at the AV node. So at the AV node, there is a junctional delay, AV junction delay. Why? The ventricle is not yet ready to receive the impulse. When the ventricle receives the impulse, it has to contract. So ventricle is still in the diastole or the filling phase, and AV node says, wait. Our master is still receiving blood. Once he completes that, let the AV valves be closed. Then I will allow you to go inside so that he will contract. The blood can go into the semilunar valves. Okay. So until the AV valves closes and the ventricle is ready to receive the impulse, the electrical impulse is temporarily suspended or withheld at the AV node, and that produces the PR interval. And this tells whether there is a conduction delay at the AV node. So this is a very important interval. What is this? We know this is 0.2. We know this is 0.12. So this must be 0.08, isn't it? So 0.2 is the PR interval, and this is the 0.12 is the P wave. So PR segment is 0.12 minus 0.2 minus 0.12, which is equal to 0.08 is the PR segment. Now the QRS I told you is very crisp and occurs in two small squares or 0.08. Then comes the ST segment, and this point is called the J point or the junction point, where the ST segment horizontal meets the upcoming wave from the S wave. The S wave will be coming to baseline, and that point where the ST segment joins is called the J point. It has got an importance. That is why we have identified it. Other points we have not identified. A junction point is important. Then the repolarization wave is the T wave, and of course the U wave is there, and the QRS interval is this much, starting of the QRS and ending of the starting of the QRS, ending of the QRS, Q wave starting, R wave ending, and this is usually 0.08 or two small squares. If it is more than 0.12, it is pathological. Okay. QT interval is beginning of the Q wave to the end of the T wave is called the QT interval. We know it should be less than half of the RR interval. Any doubt on this? Now I'm going to just show you some waves. So P wave is atrial contraction is 0.12 seconds, which is 3 small squares. PR interval beginning of the P wave to the beginning of the QRS is 0.2 seconds, which is 5 small squares or 1 big square. QRS complex is ventricular contraction, 0.08 seconds, and it occupies 2 small squares. ST segment, electrical silence, isoelectric, the fate line. T waves, repolarization wave, usually occupies 3 small squares, just like the P wave, which is 0.12 seconds. QR interval is the ventricular contraction from the beginning of the Q wave to the end of the S wave is QRS contraction, and that is 0.08 or 2 seconds. If it is more than 0.12, we say QRS is prolonged. QT interval from the beginning of the Q wave to the end of the T wave, it is 0.4 when the cardiac cycle is 0.8. It is roughly half of the cardiac cycle. It is dependent on the rate. So we require a corrected QT interval, which is called the QTC. Then there is what is called the TP segment. I didn't tell you. TP segment is this one. This is the T wave, and this is the next P wave. So between the T wave and the P wave, there is one segment which is called the electrical silence again, where in the between two cardiac cycles, heart briefly takes a little rest, and that is 0.3. So now This I have already told. Now you identify the waves. What is one? All of you can write in the chat box. What is one, or you can write in your notes also. What is two? What is 3, 4, 5, 6, 7, and 8? What is the big square like? Big square is 0.5 millivolts vertically, and horizontally it is 0.2 seconds. Small square vertically is 0.1 millivolt, and horizontally it is 0.04 seconds. That we understood. I'm identifying the waves now. 1 is the P wave, 2 is the PR segment, 3 is the Q wave, 4 is the R wave, 5 is the S wave, 6 is the ST segment, 7 is the T wave, and 8 is the TP segment. Okay. P wave atrial contraction 0.12 seconds or 3 squares or 3 small squares. PR interval P plus AV delay together is called the 0.2 seconds. It is 5 small squares or 1 big square. Q waves is equal to septal Q waves less than 3 millimeters. Any Q wave is physiological and pathological. When do I know it is physiological? When it is amplitude down in the baseline is 3 millimeters or less, or its duration is less than 0.04. Any Q wave which is more than 3 millimeters or greater than 0.04 is called a path Q, pathological Q wave. R wave, ventricular contraction, usual amplitude is around 15 millimeters, but of course depends upon the lead that you are looking. S wave is complementary to R wave, that is also less than 15 millimeters. ST segment is isoelectric line, the fate line. T wave is the ventricular repolarization, a friend of ST segment. Why I said friend? Whenever there are changes in the ST segment, there will be also changes in the T wave. So these go hand in hand. That is why there are STT changes, we will say. So whenever there is a ST segment change, there will be a complementary same side or opposite sympathetic change may be there depending on the pathology. That we will see. TP segment is ventricular relaxation, and this is the one which is reduced when the heart rate goes up. The contraction rate will be the same, but the contraction duration, but the relaxation time only is reduced when there is tachycardia. Now, how is the ECG recorded? So the recording of the ECG will be done by a small machine, which is nothing but an voltmeter. The person is connected to the leads, and there is a simple voltmeter, and the voltmeter records microvolts there. But this is of course earthed so that the patient is not getting any electrical disturbance from the surroundings. And this voltmeter, the amplification is made so that it is coming, the microvolts is coming into millivolts. Those are either visually displayed on the screen, or you can get them recorded on a paper, or you can save them onto a disk or a pen drive, or you can transmit on your as an image to your other doctor friend or anything. So this is the basic electrical understanding. It has got connecting leads between the patient and the machine, and an electrical wiring between the machine and the interface, the screen. It may be on the machine itself, it can be a separate monitor also. And that is an amplified one which we see, which can be recorded in a waveform and printed on a graph paper and seen on a grid scale on the screen. The graph like grid will be there on the screen, which you can print it. So actually when the ECG was first rather invented, what did they do was, a person, he brought a horse and he has taken 4 buckets, like glass buckets. And in the glass buckets, they are not metal buckets. In the glass buckets, he has poured saline. And in the 4 glass jars, he has put saline and made the horse stand with the 4 legs in the 4 sort of glass buckets. And then he connected the chest of the horse to one end of the voltmeter, and he connected all the 4 of the horse's legs to the other end of the voltmeter and recorded the ECG. That is the way first ECG were recorded. Today you can record ECG on your stethoscope. How far we have moved down, you see. If we were to record like that for every patient, putting his hands and legs like a horse, crouching down and putting in a glass bucket of saline, and then taking our potentials from the heart through wires, just imagine how impossible for that to be used. So that is how it has innovated. I will show you that picture of the horse also, what he did and how it, just like the blood pressure was first measured from the carotid artery of a horse. He used a water manometer, which was like a 10-floor building tall. Because water specific gravity is very lower, he required a manometer which is 120 millimeters of mercury. Is in millimeters of water, it will be very big. So he measured the BP with a glass rod, which is as tall as 3-floor building. So now we are not doing that. So thanks to all the scientific inventions. So the important precautions are the correct lead placement and good contact of the lead are important, because if you place the lead in one way, if I place the lead in another way, and ECGs cannot be compared. There must be a standard way of placing. Or if you yourself place the chest lead as V1 in one place now, and at a later time when you want to record, you place it in a different place, you see a change in the ECG pattern, which is not due to the change in the disease, but change in the placement. So ECG placement goes without saying is the cornerstone of a proper ECG recording. Likewise, we use a gel-like substance, an electrojelly, which conducts the electricity to the metallic lead there. Because particularly when the chest is hairy and you have to shave the hair and see that the skin comes into contact with the electrical lead there through a jelly. The proper earth connection is essential, because we don't want electrical disturbances to be recorded, as well as we don't want by chance a small current in the machine unnecessarily will give a shock to the patient. And avoid other gadgets plugged to the same sort of a switchboard. So if you are dedicatedly using ECG from a switchboard, no other instrument should be connected to that. Preferably mobile phones are out of the room when you are using the ECG, because each time the electrical impulse comes into the mobile phone, there could be a disturbance in the, many a time we forget this. So we keep our mobile phone on the table and start recording, we see a lot of disturbance, we were wondering what is happening, we adjust the leads. The moment I keep the mobile phone out of the room, my problem is solved. So this is a practical point. Deep inspiration will be required to be recorded in L3 and AVF, because whenever we lay down flat, the tendency is the liver pushes the diaphragm up. And when the diaphragm is pushed up, heart becomes flatter. When the heart becomes flatter, the inferior surface of the heart is not well represented in the ECG. So what I do, whenever I make the patient lay down, I ask him to take a deep breath and bring the diaphragm down and hold, and recording L3 and AVF, which are the inferior leads, which we will see very shortly. And better always compare serial ECGs if available. And also pediatric ECGs are very different from adult ECGs. Likewise, female ECGs are little different from the male ECGs. So age and sex and clinical history also are important. Clinical history is important to know whether the changes are recent or there are some old changes which we are seeing. Consider the comorbidities also that may affect. For example, electrolytes disturbances are notorious to cause changes in the ECG. So if we do not know the potassium value and sodium value are normal, then it is difficult to interpret the ECG changes in the ST and T. Make a photocopy of the record for future use, because most of the time we record it on a thermal paper and not on a regular print paper. A print paper like what you print on a document, house document, will be there for a long time. Whereas a thermal paper, the recording fades off very soon. Within a matter of 3 to 4 months, you will have a blank paper. Many times patient will give me sir, this is my old ECG. He gives me a paper. Nothing is there, because it is a thermal paper. And better to give a photocopy to the patient or a soft copy to his mobile gadget. Interpret systematically to Avoid errors. Don't jump directly to ST segment and say infarction. Start from the beginning. What is the P wave? What is the QRS? I'll tell you how to go systematically so that errors can be avoided. So these are some of the basic tips I would like to tell you about the important precautions of the ECG, and I'm going to show you the standard 12 leads, limb leads, and chest leads. Today's exercise is to get familiarized with the ECG paper, to get familiarized with the various waveforms and intervals, and also understand the electrophysiology behind that a bit, and also the duration of each of these waves and the amplitudes. And having done that, we understood what is ECG and what are the precautions in recording the ECG. Now we go to connect the patient to the standard 12 lead ECG. We call it as 12 lead ECG. Why 12 leads? Why not only one lead? Supposing I ask you to go to Taj Mahal, so as an excursion, all of you would have probably gone, or any other monument for that matter. What you go do now? You take your mobile phone, click, click, click. You keep taking pictures. And when you come back, you compare your pictures with your friend's pictures. This is good, this is not good. So you try to view the Taj Mahal from various angles, isn't it? So likewise, the electrical activity of the heart also, we don't want to use one camera and take a picture and come out and say it is good or not good, or heart has got a problem or no problem. But we would like to use 12 cameras. These are not regular cameras. These are electrical lead cameras. We are recording the electricity and not the image. Of course, the electricity is converted into a waveform of an image. So there are 12 cameras. What are the 12 cameras and why do you want to place them will be the part of the next session. Now, there are unipolar leads and bipolar leads. Bipolar means there are two poles. We are taking the potential difference between two poles, a positive pole and a negative pole. That is why they are called bipolar leads. So as far as the ECG is concerned, there is only 1 foot. ECG man does not have 2 feet. Imagine the man as a triangle with one bottom is the peak, and the bottom part is the left foot, which is called the lower part of the heart, like a triangle. And the two sides of the ends of the inverted triangle are the left and right arm. So the lead 1, so this is the left arm and this is the right arm. And I told you foot means only left foot. What happens to the right foot? Right foot is connected to the earth. Right foot is earthed, and which means that we are not going to use the potential difference from this. Why not right foot? Why did we choose left foot? Why not right foot? The answer is very simple. Where is your heart? Is it to the left side of the chest or right side of the chest? Obviously, it is to the left side of the chest. So then what you have to do? You have to use directly what is directly under the left side, and that is the left foot is the reference point. So lead 1 is a potential difference between right arm and left arm. You always know the current flows from the negative pole to the positive pole. So right arm and left arm is called the lead 1. The receiving arm is the positive arm, positive pole, this left arm, and the right arm is the negative pole. So a potential difference between them is recorded as lead 1. Lead 2 is same right arm as the starting point and going to the foot. Okay, right arm and foot, or the foot means left foot only, is the lead 2. Lead 3 is left arm and foot, left arm and foot. Okay. There is a little trick here. If a patient has got dextrocardia, you need to connect the neuter to the left foot and this one to the right foot. Not usually done. There may be a mild difference in the ECG recording, but it is better to adhere to that. So now I told you there are 3 bipolar leads. Why called bipolar? Because the potential difference is obtained from 2 points on the body, and these are limb leads because we are placing them on the limbs. That is why ECG. Sorry to note, somebody has opened the mic. Okay. So the links are here. I'm going to stop in another 5 minutes probably, and then we'll go for the continuation in the next class. So link leads are L1 being a difference between left arm and the right arm. That is the lead one. L2 foot and right arm. That is the left lead two. L3 is foot and the left. Okay. In both L2 and L3, the positive terminal is the foot. In L1, the positive terminal is the left arm. Why that is important? The positive terminal records a positive deflection when the current is coming towards it. So if the current is going towards the left arm, it records a positive there. If it is going down, so what is the impulse like cardiac impulse? Cardiac impulse is traveling from the SO node to the apex. So it is, first of all, it is downward, and it is leftward, and it is positive. Inward, upward, and left. These are the directions of the current. So this is the standard ECG for lead, lead, L2, AVR, AVL, AVF for standard 6 leads. L1, L2, L3 are called bipolar leads. L1 between left arm and right arm, L2 between left foot and right arm. Then let us see the unipolar leads. In the unipolar leads, what we do, we draw the potential difference between one point of the body, the right arm or the left arm or the foot, and remaining three are connected to the neutral. They are connected as the neutral. So this becomes the exploring lead, and these are the neutral. So the potential difference is between this one and the other thing. These are unipolar because only one pole is used, and these are current small when you record unipolar. So we have to augment them. That is why it is called augmented unipolar leads. A small a VR, small a VL, and small a. You can see the signature of Netter here. So Netter, I told you, is the wonderful person who created several medical drawings of all disciplines of medicine, including and this. Now, okay. Now, unipolar leads are right arm being positive is the exploring lead, it becomes AVR. Left arm is the exploring lead, it becomes AVL. If foot is the exploring lead, it becomes AVF. So we have 3 unipolar and 3 bipolar leads. Unipolar leads are AVR from right arm positive, AVL left arm positive, AVF left foot positive. Now coming to the chest leads, you must very clearly understand where we place these leads. These are called V1, V2, V3, V4, V5, V6. So you palpate the sort of sternum, the manubrium sterni, the junction between sternal body and manubrium is the first interspace. Go to the third interspace. So this is the first interspace, second, third. So first, second, third. The lead 1 is placed there, lead 2, 3, 4, 5, 6 in that order. And I will show you the exact positions. So this is the mid-clavicular line, and this is the clavicle, and this is the mid-clavicular line. This is the anterior axillary line. This is the mid-axillary line, and this is the mid-axillary, and this is the anterior axillary line, and this is the posterior axillary line. And I will show you the position, describe the positions. V1, V2, V3, V is the lead, chest lead, 6 chest leads. So we have 6 cameras from the limb leads and 6 on the chest leads. Total 12 cameras are recording. Precordial leads, these are also called, they are called the limb leads. These are called the precordial leads because they are on the chest. V1, 4th intercostal space, right sternal border. You see 1, 2, 3, 4. So 4th intercostal space on the right sternal border is the V1. V2 is the 4th intercostal space on the left sternal border. So this is on the exact left sternal border. And then V3 is equidistant between V4 and V2. So V4 is there and V2 is there. Between them is the equidistant is the V3 that is placed. And like an arc, it comes from here like that. And then what is V4? It is the fifth intercostal space, mid-clavicular line, left mid-clavicular line, which is your apex beat. So fourth is almost at the apex, and second is at the sternal border, and 3 is in between the two. Fifth is the anterior axillary line in the same space, and 6 is in the mid-axillary line in the same space, same fifth space. So these are the positions of the precordial leads. One thing that you need to know here is we are placing 3 cameras on the, how many cameras are there on the left side? There is 1 camera on the left side, isn't it? This is the tapping camera on the left side, and 2 here at the foot. So remember, 1 plus 2, 1 on the left side, 2 in the foot. When we come here, how many is there on the left side? 1 camera is on the left side and 1 in the foot. So that means already we have got 2 cameras on the left side and 3 on the foot here. And of course, this is called the cavitary lead. This is the right-sided lead. And when we come to the chest lead, we have 3 anterior, 2 anterior, and then these are the left-sided ones. So there are 3 here on the left side, particularly V5, V6, V4, V5, V6 are the left cameras. So heart, imagine the heart as a box. The box has got how many surfaces? How many surfaces a box will have? 6 surfaces, isn't it? So here, this box of the heart, the upper surface, the anterior and posterior joint, there is no upper surface. Okay. Likewise, on the right side also, the anterior and posterior joint, there is no right surface. So it's left with 4 surfaces. What are the 4 surfaces? The anterior surface, the posterior surface, the lateral surface, and the inferior surface. Superior, no superior because these are merged. And then right, also the anterior and posterior have merged. So there are 4 surfaces of the heart, literally we require to pick up. So we require to keep some cameras anteriorly, some cameras on the left, some cameras below, and some cameras which go posteriorly. So posteriorly we cannot record, so we keep some cameras and the mirror changes of anterior will be the posterior. So left-sided events are recorded, remember, in L1, AVL, V5, V6. Anything happening in the left part of the heart, left side of the heart are recorded in 4 leads, V5, V6, L1, AVL. Anything happening on the diaphragmatic part of the heart is recorded by the L1, AVF, L3. Anything happening on the anterior near the septum is recorded by V1 and V2. And V1 and V2 are septal, and V3, V4 are the anterior part of the heart. V5, V6 are the lateral part of the heart. So we need to understand the relationship of these things to the different parts of the heart, because when we say anterior infarction, when we say posterior infarction, we require to know which leads we have to look for. I'm again identifying the leads to you. The 12 leads are there. Out of the 12 leads, 3 are on the 4 are on the left side. L1, AVL, and then the V5, V6. And 3 are on the inferior cameras, L2, L3, AVF, where the foot is the lead from which the potential difference is picked up. And then right side, right arm AVR is the cavitatory lead, which is only a reference lead, not much used. Whereas anteriorly 1 and 2 are the septal leads, 3 and 4 are the anterior leads, 5 and 6 are the lateral leads. So we are now recording this Taj Mahal of our heart from 12 cameras, because we want to capture the information on the inferior surface of the heart, on the lateral surface of the heart, on the anterior surface of the heart, and of course through that the posterior surface of the heart also. Probably we will stop here for today, and then rate determination we will start in the next class. So what did we do in this class? We have done the ECG paper identification. We thank our forefathers who gave us the ECG, and then we went into the paper identification, the x-axis, the y-axis, and the wave patterns P, Q, R, S, T, and what each wave means, what are the intervals, and what is the duration of each of them normally. And also we identified the different waves as P, Q, R, S, T, and correlated with the cardiac cycle. Then we identified that 12 leads, how the original ECG was recorded, and what is the advancement we have today, and what are the placement of 12 leads. L1, this is L1, L2 is this plus the foot, and L3 is this plus the foot, and then the AVF always from the foot. AVL is here, AVR only one unipolar lead, and just leads. V4 interspace on the right side, V4 interspace on the left side. Then at the apex is V4 lead, and then that in between is the V3, V5 anterior axillary line, V6 mid axillary line. So we understood that lead placement, good contact, avoiding electrical disturbance are essential and fundamental for recording a proper ECG. So probably this is now around, we started around same time 1 hour ago, that is around 11:10, we started 10:10, 9:10 to 10:10 is 1 hour. So if you have any questions, I would like you to post those things, and maybe from next class onwards, I will show you the ECG center. Maybe briefly, I will show you that. I will share the ECG center to you, Leland Center. So screen sharing, do you want to continue?